Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hi, everyone. Welcome to this episode of the Gastro Girl podcast. Today, we're going to be talking about a very hot topic. We're going to discuss what a gastroenterologist wants you to know about the popular weight loss drugs. And I couldn't think of a better guest to have than the wonderful Dr. Pichamol Jirapinyo, who is director of the Bariatric Endoscopy Fellowship at the Brigham and Women's Hospital and also affiliated with the Harvard Medical School. Welcome back, Dr. Jirapinyo. So great to have you here again.
Thank you so much, Jacqueline, and thank you so much, Gastro Girl, for having me back.
Great. So let's get right into it. First of all, we've been reading and seeing and just watching tons of coverage on the popular weight loss drugs, whether it's celebrities or people that are just trying to lose weight. We've seen before and after photos. There's tons of stuff on social media, and there's lots of misinformation out there. So we really want to break it down from your point of view, because this type of drug really has an impact on the digestive system, especially when it comes to motility. And I really want to bring patients evidence-based information. So let's get right into it. First of all, what are these popular weight loss drugs? They're called GLP-1 agonists. What does that mean? And what are some of the popular ones that we may be hearing about?
Totally. So basically, GLP-1 receptor agonists. So these are the class of these popular weight loss medications. And when you break it down, GLP-1, it stands for glucagon-like peptide 1. And what this is that it is one of a very important gut hormones in human body. And this hormone is secreted in the distal ileum, which means at the distal small bowel, where it's close to the colon. And essentially, when people eat and when food hits the small bowel, that's when it stimulates GLP-1 to be secreted by the small bowel. And this wonderful hormone does wonderful things to the body. But the main important roles are, number one, it helps people feel full, so that when you eat, when you secrete this hormone, you feel like, hey, I'm full. I don't have to eat anymore. Number two, it can also help secrete insulin. And basically, insulin is another hormone that helps bring down the sugar level in the body. And then the third role that this hormone does is that it helps delay gastric emptying. So what this means is that when you eat and when you delay gastric emptying, food tends to sit in the stomach for a longer period of time so that you feel full sooner, right? Because food just keeps sitting in the stomach. So you just feel like, I'm full. I don't want to eat anymore. So when you combine all of those three roles together, this is a wonderful hormone, because once the body secretes GLP-1, you feel full and you feel like you have a lot of food in the stomach. And also it helps secrete insulin to bring down the sugar level. So very, very important hormone. Now, what is this medication? So this medication belongs to a group called GLP-1 receptor agonist, which means that this medication helps secrete more of this wonderful hormone so that you feel full even sooner. You delay gastric emptying even more, which means you have more food sitting in the stomach. And also you secrete even more insulin. And that's why this is a wonderful medication. Okay.
So what are the types that we hear about, the names? So patients might not understand GLP receptor 1 agonist. What would they be hearing about in the news?
Yeah, so you probably hear different names. So I just want to break it down into the generic names. So the two popular ones are liraglutide and semaglutide. So let's start with semaglutide, because this is the newer and more popular one. So when you talk about semaglutide, there are two medications. One is called Ozempic, and the other one is called Wegovy. And the main difference is that Ozempic was previously approved for patients with diabetes, and the dose goes up to 0.21 milligram weekly. Now, more recently, Wegovy, which is also semaglutide, was now recently approved for patients with obesity. So not just diabetes, now it's approved for weight loss. And the dose for weight loss can go up higher, so that the dose can go up to 2.4 milligram weekly. So this is semaglutide. Another popular medication is liraglutide. So this is an older medication within the same class. And the two names that you may have heard are Victoza and Saxenda. So similar to Ozempic and Wegovy, Victoza is approved for diabetes and Saxenda is approved for weight loss. And the dose is different. For diabetes, the dose is smaller or lower. And for weight loss, the dose is approved at a higher dose.
Oh, thank you for that explanation. Now, in your opinion as a physician, if someone came to you, who would be a good candidate for these drugs?
So patients who have obesity, which means having a BMI of at least 30, or if they have BMI of at least 27 with at least one comorbidity, are technically good candidates for these medications. And you can use either Wegovy or Saxenda. Additionally, if patients have pre-diabetes or diabetes, I usually check hemoglobin A1C. And if A1C is at least 5.7, they have pre-diabetes, then they are wonderful candidates for these medications. And I would try to vouch for them to be on these medications.
Now, is that the same thing as insulin resistance? We hear a lot of patients, especially as age or, hormone changes or bad eating habits, and they become insulin resistant. Does that fit into that category?
Yeah, that's in the same category. Essentially, once they become pre-diabetes, they are insulin resistant. And so the next thing I do is usually look at insurance coverage. And if they have good insurance, depending on which insurance, depending on which study you're in, then I would try my best to get these type of medications for them.
Now, we've been hearing a lot of news reports about patients who have been complaining about motility issues turning into something that's called gastroparesis, which I'm happy to have you explain to our listeners, because they blame these drugs. Can you explain, are there any screening mechanisms that are in place for patients who may be diabetic, who might be good candidates for these drugs, but maybe the motility issues need to be screened out first to make sure they don't have a motility issue going into having this drug?
Yeah, that's a wonderful question. So the most common side effects of these medications are GI symptoms. So these include nausea, vomiting, bloating, constipation, diarrhea. I have more patients having constipation, but some people also have diarrhea. And also acid reflux. So those are possible side effects. And I always tell the patients that usually they are more common when they go up to a higher dose. And the way you titrate the medication is that you start at the lowest dose, and depending on which one, if it's Ozempic, Wegovy, you go up every month. And once they get to a higher dose, they might start experiencing these symptoms. So now regarding the workup prior to starting these medications, it depends on the patients. I don't do the workup on every patient because gastroparesis is usually more common in patients with poorly controlled diabetes. So if I see my patients, they have diabetes and they do tell me that at baseline, they tend to have some nausea, vomiting, they feel like food doesn't really sit well in their stomach, then definitely I will order a gastric emptying test to see if they have quote unquote gastroparesis, which means it takes a really long time for their stomach to empty the food that they eat. So I would do that test.
And that's what gastroparesis is?
Exactly.
And
so if patients get that test and it confirms that they have gastroparesis, they are not a great candidate for this medication because it can exacerbate the symptoms.
Oh, that's great advice. Now, what kind of test is this that a patient would have to take potentially?
Yeah, so it is called a gastric emptying test. And there are different ways to do this test. But the classic way is that usually they have patients eat an egg, and there's like radionuclear labeled inside the egg. And then you can track and see how much food sits in the stomach after 1 hour, 2 hours, like every hour. And then they can compare that to a control standard and see if it takes longer than normal to empty the food from the stomach.
Now, I think I read about a breath test. Is that the same thing? Can we use that? Can they use that?
Totally. So this is a newer test, Jacqueline. It's called a gastric emptying breath test, GEBT, and it's approved by the FDA to also check for gastric emptying rate. So we routinely do this test as well. It's more convenient for the patient because they can do it from home. And essentially they have to eat like crackers that have like sample food that they have to eat. And then they have to blow their breath into a tube. And then they can check like how much radio label comes out in the exhale gas or exhale air. And that can be converted to the gastric emptying rate as well.
Oh, this is great news for patients. They have options.
Exactly, because you can sit from home and then one of the providers will just walk them through like, hey, it's been an hour, blow out into this tube.
And they don't have to have any radioactive anything in them. They're not going to turn green or anything.
Nope.
Good. So once a patient is on these medications, what are some of the side effects? Some of them are maybe normal, but some of them may be not so normal and they should see a physician. But what can they expect? I know this affects the digestive system and the GI tract the most. So what are some of the things that we could expect if we're on these medications?
Yeah, so basically like GI symptoms are not uncommon, and these include nausea, vomiting, diarrhea, constipation. From my experience, more patients have constipation than diarrhea, and also acid reflux. So these are within realm of normal. It depends on how severe they are and how prolonged the symptoms are. More commonly, my patients would say once they inject the medication, and this is a weekly injection, if we're looking at Wegovy or Ozempic, usually they say within the first 24 to 48 hours, they would experience some nausea, vomiting, maybe a little bit of diarrhea, but then they say after 1 to 2 days, symptoms go away, and then they feel okay. And then next time they inject another dose, they might feel it a little bit. If they say that, I say, and if I'm getting good weight loss from the medication and I ask them, are they tolerable? And if they say yes, then we would continue the medications. However, I do have some patients who experience more severe side effects. For example, some might not be able to go to the bathroom at all for the whole week, feel very uncomfortable from constipation. Then I may start by trying to treat constipation using some of the constipation medication. But then if it's still not getting better, then usually the treatment is to go down on the dose of the medication. For example, Wegovy comes in 0.25, 0.5, 1.7, and 2.4 milligram weekly. If they are at the highest dose, 2.4 milligram weekly, and then they have severe GI side effects, then usually my next step is to come down on the dose to the next highest dose, which is 1.7 milligram weekly, and see how they feel. If the GI side effects go away, then that is a good dose for the patients.
It's not just, okay, we're going to take this shot and we're going to suddenly like become like a size, whatever. We're going to suddenly trim down. Are there lifestyle changes, diet changes that you recommend to your patients? You can't just, give yourself a shot and sit back and eat a Big Mac and a large fry, right? There's some things that have to go hand in hand, would you say?
Totally. Just like anything with weight loss therapy, this is a multidisciplinary approach. So for all patients who are getting these medications in my clinic, we always do lifestyle modification, including diet and exercise along with the medications. So in my practice, I have a dietitian who sees all of my patients. So everyone who's getting these medications will also see the dietitian. Her name is Catherine. And the goal is to make sure that they're eating healthily. Like usually when they go on these medications, they feel full very, very soon. They don't really feel like eating. Some people say they have to set an alarm clock to remind themselves to eat. But we also still want to make sure that they eat healthy food. Additionally, you want to make sure that we're not losing muscle mass. So we always talk about exercising at least 150 minutes a week. Furthermore, you want to make sure that they do resistance workout to make sure that they gain muscle mass and not losing that part of their body.
Now, we know everyone's different, but what is a realistic, from your patient population, what is the average and a healthy weight loss? Like you said, you want to still be eating because your body needs nourishment. You don't want to starve yourself because then it's not going to be beneficial in the long term. So what would you recommend or what would you suggest for patients like they see, they may see something on Instagram where this person dropped, 30 pounds in a month. That's not realistic. What is realistic for these patients to expect from taking these medications?
Mm-hmm. So usually I go by the FDA guideline first. And the first number you want to hit is that by 3 months, you want your patients to lose at least 5% of their starting weight. And that is kind of like a cutoff that, hey, this medication works and that you should continue that medication. So for example, if patients come in weighing 200 pounds, I say, hey, by 3 months, hopefully you'll get at least 10 pounds off. So very easy to achieve with this medication. And you want to make sure that they don't have any side effects or severe side effects. After that, I usually advise them that on average, patients lose somewhere between 10 to 12% of their starting weight. If you look at the paper in New England Journal where they study Wegovy, it showed that patients lose about 14% of their starting weight at 1 year on their treatment dose. However, in that study, all patients were able to get to the maximal dose of Wegovy, which is 2.4 milligram weekly. But in real life, some patients will not be able to get to that highest dose because they have all of these GI side effects that we just talked about. And therefore, in reality, I usually say you can expect about 10%, 12% weight loss. You may get more if you eat well, if you exercise more. So you can encourage patients to do lifestyle modification and get more. But I don't want to over-promise the patient. So I say usually 10 to 12%.
Well, that's very helpful advice. And I want to draw attention to the side effects, the GI side effects. And it makes sense. It's logical. We hear side effects and we all freak out as patients, right? But if we think logically what's happening to the body with almost the control of the appetite and, making sure the feeling of fullness, and it's going to make you not hungry. And also the food is sitting there longer. It's delaying the emptying. So of course you may be more prone to getting some acid reflux. You may feel a little nauseous if the food is sitting there. So when does it become too much? So some of it is expected just by how it's working, but there are things you can do right with your diet. Do not eat fried and greasy foods, laying down right after eating. But when would the alarm bells go off for us to talk to our doctor and know that this isn't good and we should really bring it to the attention of our healthcare provider?
So a few things, Jacqueline, like severe constipation sometimes happens occasionally. Like if patients cannot go to the bathroom at all for the whole week, feel very uncomfortable, and we give them 1 or 2 medications to help them go, and they're still not able to, then if you come down on the dose and they still have the symptoms, then that might not be a good time to continue the medication. You might have to stop. Additionally, with gastroparesis symptoms, for example, if they feel nauseous all the time, they vomit severely, and they just can't eat anything at all, then also that is too much, and we might have to consider stopping the medication.
And I think there's a conundrum, right? Because patients often say they love the weight loss and they stick through all these side effects, and then they may have a motility issue like we're seeing in some of these news reports. What would you say to those patients? It's, sometimes it may not be for you, but there's other options, right? Besides these drugs.
Exactly. Like when we talk about weight loss medications, we're looking at 6 potential medications right now that are approved by the FDA for weight loss. So it's not common, but when it happens, and if it gets to a severe level with all these GI side effects, usually patients cannot tolerate them. They feel they suffer from them, and they're the one who actually say, like, you know what, I don't think I can continue these medications anymore. But sometimes they do have to say, yeah, maybe we might want to consider switching to another weight loss medication. And usually we always agree on that, like take a break, try something else, and see if these symptoms go away.
And sometimes just probably maybe the help with the lifestyle and diet modifications, it really helps educate patients to make those changes long-term without even having that drug. Maybe,
Totally.
I mean, I'm optimistic, but sometimes it's a learning lesson.
Totally.
For patients that maybe they know they could do it, if they've.
Yeah.
The other thing I wanted to say, and I know these drugs are fairly new, especially for the weight loss for some of these, but are there any long-term side effects? I know, we've heard things in the news about pancreas, people that shouldn't take them if they have some history of thyroid issues. Can you just elaborate on some of those things and clarify from your perspective as a gastroenterologist what patients should know?
Yeah, so usually before I prescribe these medications to my patients, I say there is no long-term data with these medications, but there are black box warnings for these medications. So patients with personal or family history of thyroid problem or pancreatic diseases, you might want to watch out for, but there's no real long-term data. And I know people are working on that, so hopefully we'll know more in a few years. Additionally, I always tell my patients that most likely you might have to be on this medication long term. So think of it as hypertension or high blood pressure. Once you go on a medication, there's a high likelihood that you have to be on those medications. So I don't want to tell them like, hey, you're going to go on this medication for like 1 year and then we can stop it, because there's some data that for some patients, when you stop the medication, some of the weight may come back. So they need to know that they are subjected to taking this medication most likely long term.
And how do you know like what patients would have to stay on it long term? Can you taper down? How do you predict that? And how do you know?
Yeah, totally. So usually I calculate with the patient like what weight they have to get to no longer be quote unquote in the obesity category and overweight category. And you calculate back using BMI of 30 and 25. And once they get to that number, usually patients are very happy. Then I will try to come down on the dose. So let's say if they're on Wegovy 2.4 milligram weekly, then it would start coming down to 1.7. Like try to find the lowest dose that they can stay on without gaining weight, and also while they're still feeling full and not overeating at that dose.
Oh, that's interesting. Now, I want to touch on the subject. I know there's a lot of societies that are coming out with guidelines, but we can't avoid this question is what happens for the patient that is scheduled for surgery, or maybe they're in an accident, God forbid, and they have to, go under anesthesia. How does the food sitting in their stomach because of these drugs, what do we need to know about that? And, make sure we tell our doctors or our healthcare providers that we're on this. Like, we need some tips here.
I mean, this is a great and very timely topic, Jacqueline.
Yeah.
So the Anesthesia Society came out with a recommendation, I want to say about a month ago, saying that patients who are on these drugs, GLP-1 receptor agonists, should hold the medication for at least 1 week before getting a procedure like endoscopy, for example, because they need to be sedated. But the GI societies like ACG, AGA, AHE, right now, they have not come up with a definite guideline in terms of like how long you have to hold this medication for. I think right now it's a little too early to have the real data to support how long exactly would be safe to hold this medication. However, in my practice, I do a lot of endoscopic weight loss procedures, and some of my patients have been on Wegovy or Ozempic, and now they want a procedure to augment the amount of weight loss that they have gotten so far. Or some patients actually come in wanting an endoscopic weight loss procedure so that they can come off the GLP-1 receptor agonist. So they come in with different reasons. For these patients, usually I stop the medication 1 week prior to ESG, for example, endoscopic sleeve gastroplasty. And after I do the procedure, I also hold the medication for about 6 weeks after the procedure, because during that time, they are on liquid diet. They might not get enough calories. They might not get a lot of sugar. So you don't want them to become too hypoglycemic. So I just kind of like give them a little break. And then after 6 weeks, when they advance diet to soft and regular diet, I resume the GLP-1 receptor agonist. So that is my practice. But this is from clinical vignette. We have not done like a study to evaluate if this is the best way to hold the medication, but we talk to our endocrinologist, and this is kind of like the guideline that we use at our hospital.
Yeah. And again, it's very new pretty much. And, I thank you for sharing your experience. And I think it gives our patients who are listening some, anecdote that they can take back to their provider as a way of discussion and learning and being more empowered and understanding how this all works together. And I love the way you treat your patients. You're taking them through something that's life-changing, and it's not a one size fits all. And they may go hand in hand. It may work nicely. If they're severely obese, going under anesthesia may not be the best thing at first. So maybe trying something, right, like these GLA-1 receptors, they may, help them kind of get down a little bit so that you can do your procedure safely. So this is very insightful, and I'm glad we have a balanced discussion here today, because there's been so much alarming press that we don't want to alarm patients unnecessarily from, if they would be great candidates for this, to not, talk to their healthcare provider. But at the same time, we're not saying, yeah, this is what you need to do. We just want to arm patients with the right information from experts like you.
Thank you so much, Jacqueline. Yeah, everything in medicine, there are always some benefits and also always some risk. So it's always important before you go on any medication or get any procedure to understand both the benefits and possible risks, so that you go in fully equipped, fully informed, so that when you feel any symptoms, oh, this is expected, and you know what to do next, or to call your doctor immediately and then work together to find a solution.
Great. And in closing, we've talked a lot about the side effects and things like that, but, obesity is such an epidemic, and we've had a previous discussion on other podcasts with you. What are the positive results from your patient population that you've seen? How has these drugs impacted your patients who are dealing with severe obesity and health and comorbidities?
It's been wonderful to see. A lot of patients experience a lot of weight loss, Jacqueline. Like some patients of mine are at 25 to 30% weight loss with these types of medications, and they're very happy. Additionally, they change the way they think about food, which I think is very key for long-term success. Some people say they no longer crave anything sweet. They used to love candies, and now they said on these medications, when they see it, they feel nothing. Additionally, just like anything with weight loss therapy, once people start getting some weight loss, they feel very motivated, and they start going to the gym more. They just want to work out, get healthy. So I think it motivates people to have a better lifestyle so that they can keep losing weight and also maintaining that lost weight. So it's very nice to see that people change their behavior just by getting these medications to trigger some weight loss. And then it translates to everything, either like they shopping for new dresses, or like now they say they can run around with their grandkids. Yeah. Now they can sit on an airplane economy seat, and they can now tighten the seatbelt. So you hear all of these stories, like how they can improve their function during their daily life. And it's just so nice to hear that they can achieve that goal.
Well, what's so fascinating is the way that these drugs work on the brain and the gut together, because there seems to be a connection. And I'm just going out on a limb here just from logic, but I could be completely off base. But it's so fascinating, when you say they don't want to eat sweets, the focus on food isn't so focused, right? And I think that's a lot of the battle for many of us who struggle with eating or emotional eating, stress eating, and just, not even being mindful about what we're putting in our mouths. And if there's a way that there's a mechanism that the way this is working in the body, it's just fascinating to think. Mm-hmm. Mm-hmm. And it helps with other things, right? Like cardiovascular, blood pressure. I mean, I've been looking at some of these papers, and, even though there are potential, side effects for certain patients, the benefits to others, the right patient for these is huge, and like potentially life-changing and potentially life-saving in the long term.
Totally. It translates to improvement in your pre-diabetes, diabetes, insulin resistance, fatty liver. Like there are published data on the benefits of these medications on cardiometabolic diseases, and it's very nice to see.
Well, this has been fantastic and so insightful. Before we go, is there anything else you'd like to say to the patients if they're thinking about this? Any tips for talking to their provider about these potential medications?
Yeah, so I think if you are suffering from obesity and are looking for a weight loss solution, this is another potential therapy for weight loss. It's a newer class of weight loss medication. So definitely look into it. You can mention it to your weight loss doctor, or some PCP primary care doctor also prescribes these medications. And depending on your health history, your doctor may do some workup prior to prescribing this medication. Additionally, I just want to caution about potential GI side effects that we talked about today. It's not uncommon, but it is something that we can work around. But I want to make sure that everyone is fully informed before you go on these medications, so that you can gain the most benefit and minimize side effects with this medication.
And there's no need to suffer in silence just for the weight loss. There's other options, correct?
Exactly. Like, in addition to these new medications, there are several other therapies for weight loss. So if in the end you cannot tolerate these medications, it's not the end of the world. There are other medications, there are endoscopies, there are surgeries that can help you with the weight loss. So definitely reach out to your provider. Do not suffer in silence, like what Jacqueline was saying.
Well, thank you so much. I can't wait to have you on again as we get more data and more understanding of how these affect the body and the digestive tract. Thank you so much as always, and we look forward to having you on again.
You're welcome, Jacqueline. So nice chatting with everyone.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.